Hi, everyone, and welcome to the show. Well, individuals with chronic kidney disease have an increased risk of developing limb-threatening plaque buildup in their leg arteries that restricts blood flow, a disorder known as peripheral artery disease, or PAD. That's why Dialysis Access Solutions president and patient advocate Terry Litchfield, who fought alongside her husband Bill, a dialysis dependent CKD patient, for more than 50 years, is sinking her teeth into prevention efforts and advances in treatment for those with advanced disease that tends to settle in the calf and foot arteries, which are tougher to tackle. We're going to talk with Terry about her entire journey to trying to have an impact on CKD and PAD. But first, I just want to let you know that Dr. John Phillips is in the middle of a complex case over at Ohio Health. He's going to try and join us as soon as he is done saving the piggies of a very lucky patient over there in Ohio. And so when he jumps in, we will definitely include him in the conversation. But meantime, it is ladies' conversation. Terry, thank you so much for joining us.
Thank you, Kym, for having me this evening.
We really, appreciate you coming in. Our conversation yesterday, preparing for the show, was just incredible. I think we talked for a couple hours.
It was
So
great.
much to
It was
talk about.
great.
I'm inspired so much by your passion for PAD, and I want to get to how you developed that passion for PAD, but I assume it started when you met your husband, who was a CKD patient.
It really did. I was right out of college. I went to work for the National Kidney Foundation, and I was at community services. I did events. But one of the things I really want to start with is, kidney diseases. CKD, chronic kidney disease, is a real devastating illness. But everyone on this call has a part of chronic kidney disease and PAD and chronic kidney disease because we're taxpayers. And every $100 we pay in taxes, $1 goes to kidney dialysis programs.
Oh, I
And
didn't
so,
know that.
yes, there are less than 1% of the patients who have Medicare, and Medicare covers any kidney disease patient, no matter if they're 65 or over. They can be less than 65. But they're less than 1% of the patients, and they consume 7% of the Medicare budget because
Wow.
they have dialysis. And really the way that they were connected is two ways, and why I've always been interested in saving legs and making sure patients are walking around started with the dialysis world. But really, when I was a newlywed, I worked at Texas Heart Institute. And those were the days when there were a lot of amputations, but we were trying what are called bypass surgeries to try and get blood flow down to patients' legs that didn't have adequate blood flow. And to me, it was a really, really impactful disease. And the surgery, where the surgical incisions went up and down the leg, and
Right.
and they really didn't heal well and often ended up with amputations. But amputations for me is the final failure in this whole equation. In the dialysis population, we have over 10% of our patients start dialysis with some type of amputation. So you go into a dialysis unit, yes, and there are many walkers and wheelchairs, patients coming in on stretchers. And a lot of the dialysis population amputation epidemic is related to 3/4 of the dialysis population has diabetes. And so that same disease that often affected and caused their kidney failure actually causes the inability of really to keep all of the vessels. So it's vessels that feed kidneys and hearts and legs. And so they enter into dialysis with a number of them having amputations. As a matter of fact, it's such a big problem. The kidney disease benchmarks called KDOQI, the practice guidelines in this country, state very clearly when a patient starts dialysis, they should be assessed for absence or presence of peripheral artery disease, because we know that if they end up with an amputation, it is almost a death sentence. It is very rare for a patient to survive past several years on dialysis after a non-traumatic amputation. And it's just it. And so always, I would ask questions about why so many amputations. I understood that, but why so many more amputations? And in that time, they didn't do in the dialysis units any foot screening or any testing for it. And so to me, it's, 80% of the dialysis population, it is estimated, has some form of peripheral artery disease. 80%. Because
and can we go back to the basic, because we have a few questions that are already coming in, and one of them is just, can you explain further? I know you're not a doctor, you're not a clinician, but can you just go down to the basics of CKD, chronic kidney disease, and get into why in which these patients are more apt to advancing to gaining atherosclerosis in their arteries?
So first of all, end-stage CKD, end-stage kidney disease, is a disease typically of the elderly, so average 64 years of age. And so as we age, we have atherosclerosis. We do get often plaque in our vessels, but
right.
it does get worsened by smoking history. So about a quarter of the dialysis population are either smokers or were smokers at some time. And then you add in 3/4 of them having diabetes, which worsens any macrovascular disease. You have almost a trifecta effect. And so they have already disease states. Hypertension is the second most common reason for patients end up on dialysis. And so these are primary causes from other diseases. High blood pressure and diabetes are by far the most common reasons patients end up on dialysis. Either they didn't know they had high blood pressure or diabetes, or they didn't adhere to some of the treatment regimens. And still in this day and time, as much as we hear about dialysis, many patients start dialysis after a visit to the emergency room when they feel quite ill, and it's found that their kidneys are totally shut down.
Wow, so that's even a failure in and of itself, where doctors should be working with patients, or is it that it's more on the patient and the patient's not compliant?
Well,
or a little bit of both?
It's a little bit of both, but what we do see in the renal data system, that unfortunately poor patients and patients from minorities tend to have later presentation of kidney failure, likely as a result of either they're in areas where there aren't specialists, or they may not have the insurance. Sometimes economic barriers to their obtaining care. So if you don't have insurance, for example, you may not go to the doctor.
So if a patient is diligent, they get diagnosed early with chronic kidney disease, and they're compliant with, let's say, medications, their diet and their exercise regimen, is it possible to avoid peripheral artery disease in your experience?
Yes and no. It's also even able to slow progression of kidney disease. There are a lot of new drugs out that can slow progression. And if you get early diagnosis, the peripheral artery disease information is quite overwhelming. if you start with a patient who has early peripheral artery disease and you get them in a walking program,
right,
and you get them in the right medication that actually helps lower the cholesterol in their blood, and you keep monitoring them, you can actually, there's some quite good literature about you can reverse the effects of peripheral artery disease when it's in its earlier stages. As a matter of fact, Medicare several years ago added as a Medicare benefit supervised exercise therapy for PAD. So a patient,
that's when it's available, right? There's
I,
so few facilities that actually have it. Many have the cardio rehab programs, but very few have that set program.
I have to say, I agree with you. And the pandemic took away many of the centers that did exist. And then we still have, and I'm going to talk about, I'm a patient advocate, patient barriers to supervised exercise therapy. So when you consider a patient, if they're in a Medicare Advantage plan, and even if they're in Medicare, they have copays. So
right.
they have to often take the bus and walk, their legs already hurt, and then they have to pay the bus, they have to pay the copay, and then they have to travel back home and take the bus again. And this is several times a week for a period of 6 to 8 weeks. And so patients don't always have that much money available to go somewhere and watch somebody, watch them walk.
And coming up right here on the Heart of Innovation, we're going to actually have a solution to those barriers impacting exercise therapy access in just a moment. So stay with us. Hi, everyone. Welcome back to the show. We are still waiting for Dr. John Phillips to finish up a complex case, hoping he's going to finish before we are done with today's broadcast. But you know what? Saving the piggies is the first priority, and that's where he is on the front lines helping a patient at Ohio Health. Meantime, in studio, we have Terry Litchfield. She is the president of Dialysis Access Solutions, and she's also a patient advocate for folks with chronic kidney disease who also may have peripheral artery disease, those blocked arteries, and mainly the leg arteries. So we were talking before the break about ways in which we can actually stall progression of peripheral artery disease, not only in CKD patients, but in all patients if PAD is caught early. And one of the ways in which we were discussing is through an exercise program. Supervised exercise therapy was approved by Medicare, but it stalled out just a bit over COVID. But in fact, I just was reading a study from Northwestern University about the fact that patients saw a more than 50% improvement in their symptoms in walking distance through a home exercise regimen versus more than 30% improvement in symptoms and walking distance in a supervised exercise therapy program on a treadmill. And I thought that was interesting because the way to my heart, Terry, my organization, which supports patients with PAD, has its own home walking therapy program. It's not really supervised per se, but it provides accountability because it sends the patient a text every day. And it's a text-based program by which the texts will guide the patient along their walk based on whether they're reporting they have claudication, whether they're reporting that the claudication led them to stop, or whether they're ready to completely stop the program for the day altogether. And they have their own dashboard. They can track their walking progress, and doctors also have access to their patients' data through that program. So it's kind of interesting. And that was the reason I started that, is because for a couple of years, the first couple of years in doing The Way to My Heart, we were actually paying the copays for patients in Mississippi and another couple states in the South to actually participate in the program. And then the patient still wouldn't even finish the program. And I almost wonder, because I haven't seen the data yet, for a general supervised exercise therapy program not involved in the study, what the retention rate is. Because with cardiac rehab programs, I think they only have a 40 to 50% retention rate in the majority of those programs. Have you seen anything in terms of compliance with the set programs for PAD patients?
The dropout is quite high. So
Is it
only about a half of the patients complete. And there's
still?
a whole host of reasons, but a lot of them are logistical. But some of them are very real financial. But I love the idea of, because I think patients, what I really love about remote patient monitoring of anything is it engages the patient, because then you're not a passive participant, you're an active participant. And you can really change the dynamics of where you're headed.
But it's interesting because a lot of the remote monitoring systems there's still a heavy burden on the patient. For example, my dad ended up with a blood pressure monitoring system from the VA just the other day. It came in a big box. It had multiple boxes in the middle. Then he had to set up the Bluetooth to it. I mean, he's 83 years old. I mean, while he is more tech savvy than most 80-year-olds, I think, he was even struggling with it. And he was like, "Are you serious? I have to spend 15 minutes per day monitoring my blood pressure." And then also, I received a call today from a gentleman who was referred to us by his doctor for our walking program. And our walking program is so simple. It's text-based. They get a text every day and it just walks them through it. And he was like, "I don't want to have to hold my phone when I walk. I don't want to have to actually monitor anything. Can't I just give you a call and you can just be on the phone and I'll walk and I'll just tell you what I'm doing?" I mean, they just could not be bothered. Can't we just do it by osmosis?
What a shame. But there are things, and I have to say that there are things that a patient can do to help reduce the burden and actually reverse certainly the symptoms of peripheral artery disease, which is why there's really good evidence, which is why Medicare chose to cover it. And now we have the operational issues of they're just not being utilized and they're not available. And that's a real problem.
I always tell patients, I'm like, it was a lot of work getting into it and it's going to be a lot of work getting out. Right.
That's true. That's
And I'm
true.
curious, going back to your story and your involvement, you seem to have so much passion, for what you do as an advocate, and a really great passion for the subject matter altogether. What really sparked this passion? It's one thing to have a career and to say you started out at the National Kidney Institute, I believe, and then you ended up continuing to pursue it even further at the Texas Institute. But what really drove you forward to really truly immerse yourself into not only the field, but the advocacy aspect of it? Was it simply being alongside your husband in his journey?
I think that it was a perfect situation. So I worked for the National Kidney Foundation. So I got to help kidney patients every day, and I loved it. So I decided to go get a master's in public administration. And my master's thesis was rehabilitation in kidney patients. What influences success? And so I interviewed, I worked for National Kidney Foundation. So they gave me a patient list. This is before HIPAA. They gave me numbers and names. And I called these patients because they had been on dialysis in those days. That was a long time. This was the late 70s, more than 10 years. And my husband ended up being the patient I had a terrible time finding, because he was always out working, doing something. And I was convinced I had the wrong person, but he was the right person. And so when I met him, I loved his attitude. But he was one of the earliest kidney patient advocates. For those of you that don't know the story, Medicare is a relatively new rule, a new insurance, a new law that was passed in I believe 71 or 72. And when there were discussions about Medicare, a national health insurance for the elderly, the kidney patient organizations, not the kidney doctor organizations, decided that they needed to get that type of coverage because most insurance companies decided it was pretty experimental and they weren't going to cover it. And so the early patients were under a US Public Health Service grant that was about to run out. And so the kidney patients made Wilbur Mills, and he was the Senate finance head. He had public hearings where you could come and have your day at Congress. And so these kidney patients, 4 of them went in, and one of them dialyzed before the Senate Finance Committee to show that it wasn't experimental. And that turned the tide. They actually amended the legislation to add kidney disease patients, no matter their age. And so my husband, who was working at the time, an engineer, and he would go to DC, he would make, he really showed early on, and he said, I'm not doing this for myself. I'm doing this for every patient that deserves a chair to sit in. And so when I interviewed him, he shared that, the advocacy you have to do for any disease is that many patients don't raise their voice. They don't get heard. And so I suppose part of my role is to raising my voice to give voice to others. And that stuck with me. And then I realized that his can-do spirit is something I'd like to synthesize for my patients. And then, time transpired and we got married. And he always instilled in me that we need to volunteer. We need to give back to this community. So he was a home dialysis patient for 20 years. And new home dialysis patients for UTMB in Galveston would come to our house and watch how well, he did it because he was an engineer and liked to do almost everything himself. But, caregivers. And so that's how I got into the advocacy side. And I'm one of the few people in the world that has been lucky enough to have a vocation. I'm in healthcare, and I ended up the last 30 years in just dialysis healthcare world. But I have a vocation and an avocation. I love helping patients with kidney disease and related diseases and advocate for them when they either can't, or help getting people together to advocate with unified voices.
We'll come back right here on the Heart of Innovation. I kind of want to hear the catalyst. I know we might digress a little bit, but I'd like to hear the catalyst for your husband. Well, before that, this patient turning into a possible love interest. So stay with us right here on the Heart of Innovation. Don't go away. Hi, everyone. Welcome back to the show. We are talking to Dialysis Access Solutions President and patient advocate, Terry Litchfield, who has committed her life to advocating for patients with chronic kidney disease and related diseases, such as peripheral artery disease. Before the break, we started hearing her story on how she started getting immersed in chronic kidney disease and her passion for advocacy. And it really came down to her husband and fighting alongside him, and his passion for advocacy that came long before he even met Terry. Terry ended up meeting her husband because she was working for the National Kidney Institute and was trying to put together her master's thesis. And he was one of the patients that she was supposed to interview, but she had a hard time trying to find him. And when she finally did, she was drawn. Terry, I assume you were drawn to his passion, but I'm curious how that passion turned into a marriage. You can find someone, they could be passionate about what they're doing, passionate about advocacy, but what was the catalyst that truly turned him from just a patient that you were to interview to a love interest, someone that became your lifelong partner?
Well, I tell people all the time, you never know when Mr. Right is in the wrong place. And so when I met him, I just loved his spirit for life. But then he had what I always considered the weakest pickup line in the world. Oh, no. When we met in person, because we had multiple phone conversations. When we finally met in person at a kidney meeting, he said, "Oh, I know your brother." And I'm like, I'm thinking to myself, you don't know my brother. And so, he was like, "Oh yeah, I do." And I'm thinking, no, he doesn't. He was cute. I went home after the meeting, and I live with my brother. And so I came back that Sunday night after a few days in DC, and then the phone rings, and then my brother hands me the phone. I'm thinking it's one of my brothers or sisters. And I said, "Who is it?" He says, "It's Bill Litchfield." I go, "You know him?" And in that smallest of worlds, they were both engineers in the oil and gas industry, and they did know one another.
Oh,
And
no way.
so what Bill would do is he would come and visit my brother in New Orleans, and he would always want to talk kidneys with me. And then it progressed such that I realized that his dialysis didn't matter to me, that what mattered to me was him. And so we were married over 30 years. And so considering, you don't ever know how long somebody's going to survive. And one of the early doctors told me, don't let dialysis be the reason you don't marry him. We don't keep that date book. We don't know when the end of our life is going to come. Don't let that be the barrier. And I just jump right in. And that's, how he would tease me and say, "Yeah, I got a trophy wife." And he would then, and I would smile and be all excited. And then he'd say, "I'm not quite sure what the trophy's for, though." And so we tried to keep everything really fun, but also, we had some serious things, but we used humor a lot. And the three things that Bill attributed to his success was, first of all, family. We had a big extended family, and faith, no matter what your faith is, having some faith. And then his third was to really listen to what the doctors say and educate yourself about what you need to do to stay the healthiest you can be with whatever disease you have.
What is the most incredible memory that you have of an impact of both of you together as patient advocate powerhouses on your effort in fighting for those with CKD?
That's a hard question, but I have to say what really does hit my memory was working together to help develop and create and build Camp Cullen, a dialysis patients for kids on dialysis.
Oh, wow.
Because advocating, people don't often think about a child on dialysis and what they need, even if they get a transplant. And so we did that together. And then in later years, when I went to work to start a company, Lifeline, that did care for patients' dialysis access, he was very instrumental in being the voice of our patient. Everything from helping us decide which chairs in the waiting room were going to be comfortable, and it gave us a groundedness at a company level, that if we wanted to do something for our patients, if we wanted to do something for Bill, he was our any patient, that we were going to do it for everybody. And if it was something we weren't going to do to Bill, we weren't going to do it to anyone. Mm-hmm. And so it's that, humanness and that partnership that we had that allowed me to have a much better patient advocacy focus, patient satisfaction scores, and engaging patients and patient committees. So he was one of the first patients that got, when he went to in-center dialysis, getting the dialysis centers. Now I believe they're required by the networks that you have a patient advocate on each shift. Love so it. That, that you can really change. You can change the progression of how a patient is taken care of.
And what happened after Lifeline? Is Lifeline still around?
They still are. I retired when actually even at Lifeline, probably about 15 years ago, when peripheral artery disease treatment started being performed outside of hospitals in specialized office surgical settings or ambulatory surgery centers. We studied it because I just can always remember the trauma of amputations. And then each year in the US Renal Registry, they report the number of patient deaths and the causes. And so it continued to dwindle our dialysis patient numbers. And so that's when we really started working closely with the peripheral artery disease experts, as well as, the vascular surgeons and the podiatrist and the nephrologist, to try to have a more holistic approach toward both recognizing and diagnosing PAD in the dialysis patient or the new dialysis patient, and treating it aggressively to avoid amputations.
And that was through Lifeline?
We had Lifeline, and we had, there's a coalition called the Cardiovascular Coalition.
Right.
And they sponsor things like PAD Awareness Month activities, September. And we worked together with the Society for Interventional Radiology on Legs for Life programs that were public screening programs, because everybody in America knows about a heart attack. You know somebody that's had a heart attack. But what you don't realize is that peripheral artery disease, when you get a total blockage in a leg and critical limb ischemia, that's a heart attack of the leg.
Yep.
And it's the most serious disease that we have, with outcomes worse than many cancers that nobody knows about. So I'm very happy to hear you
curious on the
asking.
year. Yeah. I'm curious on the year. When did you start seeing this correlation between the two? Because that was back when you were with Lifeline. So that was quite a while ago.
Well, it was probably 2008, 2009.
Okay, that wasn't that long ago. Okay.
No. So, you
went on, you retired. I don't consider you retired, but you retired from that company. But you went on to also have a relationship with DaVita, a dialysis center.
Well, DaVita actually bought Lifeline from Baxter.
So that's what I was going to ask.
We were a business unit. They aren't any longer, but we were a business unit of DaVita. And so when I was at Lifeline and we were part of DaVita started a foot screening program called Step Ahead. And so we were able to advocate. And then that was at a time when we were developing certain advanced centers that could actually do screening, diagnosis, and treatment in our centers.
And coming up right here on the Heart of Innovation, we're going to find out why these centers are no longer doing these foot screenings on a regular basis. So stay with us right here on the Heart of Innovation. Hi, everyone. Welcome back to the show. Dr. John Phillips is still heads down helping to save some piggies over there at the Ohio Health. He told me beforehand he had a very complex case. He wasn't sure if he was going to get here in time, but he is going to try. So we're still waiting. We only have one more segment left. So crossing our fingers, he can at least jump in and say hello. But if not, we are going to continue the conversation here with an amazing guest. We have Terry Litchfield. She is the president of Dialysis Access Solutions, and she's a patient advocate as well. Before the break, we were talking about how DaVita ended up buying Lifeline, which was a company that she founded long ago. And they had these foot screenings for PAD, but we don't see those happening on a regular basis anymore. And so I wanted to hear the story from Terry. What happened to them, or has anything happened to them?
Well, so both the biggest DaVita and Fresenius actually were doing foot screening programs to try to identify patients at risk. And during the pandemic, we saw a real decline in the ability to do foot screening due to staffing shortages, but also there were sometimes raised issues of infection control if patients had foot infections. And there was, frankly, not a lot of opportunities in the pandemic to get patients with subacute PAD actually seen places. And so I have recently heard that now that staffing levels are getting back up in dialysis units, that the foot, and they're not really foot screenings, they're foot checks. They because the government actually regulates what you can do in a dialysis unit. And if it's a Medicare patient, there are certain things that the government allows to be done in the conditions of coverage under the monthly the payment that the dialysis units have. And despite 80% of the patients at risk for PAD, foot care, foot exams, and PAD treatment is not in the bundle for ESRD. In the world of regulatory, there are a lot of things. We are very blessed. Very few countries have national coverage of dialysis. And so the bigger players have really stepped up to try to identify foot problems. And so we expect to see, I heard just recently from DaVita and Fresenius that they're getting ready to publish some of their results on what they found on the foot screens that they're doing. But they are limited somewhat by the ability to do things outside of the bundle. That's what they call it in the dialysis center. And so these are patients that, have so many diseases. It's really hard. And then honestly, some of the logistical issues that are resolving now, but when you are short staffed in a dialysis center, you may not have the staff available to take shoes on and off and do a foot check and put the shoes back on. So, but what I will do is try to get you an update so that we can share to all the listeners out there, how is it going? Because you would hate to think that somebody on dialysis, a lot of the diabetics have a condition called neuropathy of their feet. So they
Right.
may not be able to feel their feet. So they may not even know
Nope.
that they have a wound on their foot. And I can remember several patients in California. One was a gentleman, we were doing foot checks, and there was a roofing nail in the heel of his foot, a
Oh
roofing
no.
nail. And it was a heavily calloused. And I said, oh my goodness, doesn't this hurt? He goes, I haven't probably felt my feet in about 5 years. And the doctor that was along with me said he has a severe diabetic neuropathy, and he can't feel it. And so there is a wound, and you could see the roofing nail. And of course, he got sent straight away for a vascular referral because there was a wound that, and I asked, of course, I was a bit naive. I said, well, you didn't see it? And he was a rather heavy fellow. And he said,
Right.
honey, I haven't seen the bottom of my feet probably in 25 years. And so he didn't know he should be looking at his feet. And so there were also sometimes we would take shoes and socks off. And I can remember in a younger man, he had a gangrene of his heel, had no idea that he had gangrene.
I had a patient that came to me and said, hey, my wife said that, I have this, something on my foot, and she found your website, and we don't know what it is, and it really smells.
Yeah.
And I was like, you have what, gangrene? Time to go to the emergency room. I mean, he was like, I didn't feel it. I had no idea. And he's like, I wear socks all day. Then I even wear socks to bed because my feet my legs are cold. And, so they do need to have regular checkups. And I'm curious in terms of your experience, if it's not the the responsibility of the dialysis center? Whose responsibility is it, or how do we give the responsibility to someone other than the patient to require foot checks of every single dialysis patient, especially when it is these amputations are so prevalent?
So that's really where, between the dialysis centers stepping up, but also the kidney programs have now created these various what they're calling value-based care programs,
Right.
where there's a much more holistic approach to patients. And so you have really exciting things happening, like over in San Diego at Balboa Nephrology, they're actually pilot testing screening of all of their patients through a relatively new device, because to make it easier and more accessible for patients. So, you have these pockets of innovation emerging because these diseases are so conjoined.
So what are you involved in now? It sounds like you have your fingers in a few different pots here, all, with the same mission, the same goal. Can you share some of what you're working on with us?
I'd be happy to, because one of the things at Lifeline that I had the pleasure of working with were the research studies. And so first in man or new to man. And so I've always been excited about new things. And so a few years ago, when I was still at Lifeline, we had the pleasure of working early on at a center level, research level, with the Ellipsis percutaneous fistula creation for access device. And that really spurred me on to look for other things that are innovative. So now I have a lot of other projects where people ask. I always want to be their patient advocate, always, but also just looking at the new stuff coming down the pipeline.
And I think that's what's most exciting is, in our conversation that we had prior to this, what made me most excited that you were so up on the advances in technology and treatment options, especially for PAD. It was blowing my mind to hear you just be able to, to hear off the tip of your tongue the terminology on pedal loop reconstruction and retrograde approaches to being able to revascularize these patients and all this stuff. And I was like, wow, have you ever been in one of the procedures
Oh,
in the
yes.
cath lab? You have.
Many. So yes.
Is there one that stands out the most to you in terms of the experience and outcome?
Yes. There was one where the patient came in where the leg was cold. It was gray in color, and went in, and the doctor said this, and it was a very, very strict lesion. And then he opened it, patient went to recovery. And of course, I went to go see the patient in recovery, and the leg was warm and pink, and there were pulses. And I knew in my heart, I'm not a clinician, but I knew in my heart that that wound that was very ugly to look at was going to heal because his leg was alive again.
Isn't it the most rewarding thing? That was what really inspired me to transition from journalist to activist, in a sense, or advocate for these patients, because seeing, that moment and where that patient has gone from, I can't walk, I'm in a wheelchair, to suddenly they're able to walk out on both of their feet without any sort of pain. It is just the most incredible moment to actually witness and be a part of. And coming up right here on The Heart of Innovation, we're going to hear Terry Litchfield's final thoughts and what's next for her. So stay with us. Hi, everyone. Welcome back to the show. I just got off the phone with Dr. John Phillips, and he just got out of his case. It was a success. He was able to save the piggies of his patient, and he's texting with me right now, and he's finishing up the paperwork. And as any clinician and physician knows that paperwork is long and tedious, especially after a procedure. So he won't be joining us this show, but thank goodness we have Terry Litchfield. She is the president of Dialysis Access Solutions and incredibly powerful patient advocate fighting for life and limb for those with chronic kidney disease and other comorbidities, including peripheral artery disease. Terry, thank you so much. Before the break, you were talking about your experience. You've actually been in the cath lab for these limb-saving procedures like I have, and it's been incredibly powerful. I'm curious, from your experience and being in the cath lab, being with these patients, being on the front lines, what is some advice that you have from your journey that you would share with CKD patients and PAD patients to help advocate for themselves for better life and limb-saving care?
Yes, the first thing I tell every patient to get a notebook. It can be a regular notebook, and write down the questions you have before you go to your doctor. That way you get your questions answered. And do as much research as you can, or have a son or daughter, somebody research your disease and know your treatment options. Ask for education, ask for educational materials, because you want to be as informed as you can. And if you're not a doctor, most patients are not doctors, find your voice. Don't be afraid to ask the question, particularly about treatment options. And if you're a diabetic, for example, it's really important that you have your foot checked regularly, and you need to get your loved ones to help you check your feet, see if there are any blisters or sores that you may not be able to see. But be engaged, be informed, be educated, and that all leads to your being empowered for whatever disease you have.
Were there any questions that you developed along the way that you now say, oh my gosh, I'm not going to let any of my chronic kidney disease patients leave the room with their nephrologist before they ask these questions?
Well, there are a couple of them. For example, one of my pet peeves is a physician or any provider asking, giving them a diagnosis, a serious diagnosis for the first time, and then they rattle a few things off and ask, do you have any questions? Well, guess what? The answer is no. They don't know what questions to ask. And so I will always tell a patient when they are faced with that, turn that around and say, I don't really know what questions to ask. Please ask for the questions I need to know and give me the answer. And so you sometimes have to coach them to be able to be vocal enough and to also do it respectfully. But the truth is many patients don't know what questions to ask.
No. And that's why, with the weight of my heart, we help a patient prepare for all appointments. I don't care what it is. If they're in our system and they have PAD, I'll even help them with critical questions to ask their nephrologist or their primary care physician or their cardiologist. And we work on making sure that we have their story together and some critical questions to bring along the way. But I love your idea to say, well, doctor, what questions should I be asking? And also along with that, what questions do patients not ask you that they should, which will help to improve their prognosis, which I think could be helpful. Terry Litchfield, we really appreciate your time. What website can people go to find out more and to hire you as an advocate for them?
Okay, it's www.dialysisaccesssolutions.com.
Thank you so much for all you do. We appreciate all of your effort in helping to save life and limb.
Thank you.
The Heart of Innovation is for educational and informational purposes only, and advice and views shared are not a substitute for medical advice from your own supervising physician. Do not act on any information provided in this show without the explicit consent from your own healthcare team. If you think you are having a medical emergency, call your local emergency number or go to the nearest hospital or emergency room.